Welcome to our CE session. This month's CE session is Introduction to the Antimicrobial Stewardship Program. My name is Sundus and I'm an infectious disease pharmacist working at Shifa International Hospital. Before I start this activity, I would like to disclose that I do not have any financial relationships or any commercial interests to disclose. By the end of this learning activity, you all should be able to appraise the significance of Antibiotic Stewardship Program of Shifa International Hospital and how to employ different strategies in order to improve the stewardship outcomes. Also, you should be able to identify the challenges which are being faced by the Antibiotic Stewardship Program. Now let's start with the definition of stewardship. The word stewardship itself means supervision. Antimicrobial stewardship would simply mean supervising the use of antimicrobials or monitoring their use. The IDSA, SHEA, and PIDS all have collectively defined antibiotic stewardship as coordinated interventions that are designed to improve and measure the appropriate use of antibiotics, and that includes promoting the selection of appropriate antibiotics, including the appropriate dose, duration, and route of administration. Now here, coordinated efforts, coordinated interventions mean that antimicrobial stewardship is a team effort and not a one-man show. Although being healthcare professionals, each one of us is responsible for this noble cause of fighting the AMR and using the antibiotics responsibly. But when it comes to implementing antimicrobial stewardship program within a hospital setting, you require an entire designated team in which all the members are dedicated and committed towards the implementation of this program, and all of the efforts are coordinated. The field of antimicrobial stewardship has advanced dramatically over time, and now we have much more published evidence as there are different set of guidelines available, such as the CDC guidelines, the WHO, or the IDSA guidelines. Antimicrobial resistance, which is abbreviated as AMR, is happening in all parts of the world. And ever since the discovery of antimicrobials in the early 20th century, resistance has been increasing. WHO has identified the issue of antimicrobial resistance as one of the top 10 global public health threats that the humanity is facing right now. So AMR is a global threat, and although it differs by country or geographical regions, the lower and middle income countries will suffer more as we have limited resources and we have poor infrastructure. WHO in 2015 came out with a global action plan and mentioned the need for antimicrobial stewardship. And this plan was endorsed by all the countries, including Pakistan. South Asia is also known as a hub for MDR bacteria, and in Pakistan, NIH is the custodian of AMR surveillance. NIH has also given its own plan, which is the National Action Plan Against AMR. It was given in 2017, and it also highlights the importance of establishing antimicrobial stewardship programs in hospitals. We are facing a global shortage of innovative antibiotics while AMR is increasing day by day. In 2020, WHO received a record number, that is more than 3 million of infection cases along with their AMR results, and none of the 43 antimicrobials that are currently under development address this issue of AMR. So the slow pace of antimicrobial development does not match the fast pace of the emerging resistance. The world is slowly heading towards a post-antibiotic era in which there is a possibility that simple infections such as strep throat or infectious diarrhea could kill people. We need to not only develop new antibiotics, but we also need to conserve the already existing ones. Recently, in March 2021, first ever systematic review was published that analyzed the data of AMR in Pakistan from the last 10 years. And it looks like E. coli shows highest resistance against the first-line agents. The data has shown an increasing trend of Salmonella resistance against the fluoroquinolones, and our H. pylori resistance against metronidazole is more than Malaysia and China. Gram-negative rods such as Acinetobacter and Pseudomonas resistance against carbapenems and colistin is also increasing, and our MRSA and BRE rates are quite high. So previously, a meta-analysis was also published in 2018, which highlighted the emergence and prevalence of ESBL and Enterobacteriaceae in Pakistan. Unfortunately, although we are participating in the global antimicrobial surveillance, these antibiotics, this issue is not being prioritized at the moment, and we lack the resources and funding from the Health Department of Pakistan. And according to one cross-sectional observational study, we are not knowledgeable enough about this AMR crisis. So what does AMR do? AMR can lead to increased healthcare costs. The infections due to these multi-drug resistant organisms, they are often difficult to treat, and they're associated with an increased mortality. And they also require longer duration of treatment. So the resistance to the first line agents would obviously mean you have to go and pick the broader spectrum antimicrobials, and which are obviously quite expensive. Also, this increasing AMR is a major threat to the modern day surgery and cancer chemotherapy, because we know that these patients have an compromised immune system and they are at a higher risk of acquiring infections. So modern day surgery would also be unimaginable without the antimicrobials. So nearly half of the antimicrobial use in hospitals is unnecessary if you closely look at it. What are the benefits of antimicrobial stewardship program? It improves the patient outcomes. A number of studies have already proven this, that hospitals who have strong or successful stewardship programs have lower rates of resistance, and these programs have been shown to decrease the use of antimicrobials. The ultimate goal is to prevent infection with minimal toxicity and minimal impact on the resistance. As this program is all about optimizing the resources and cost savings, this program is pretty much self-sufficient. Hospitals often have finite resources. They have and they do not have much data or evidence to assess whether the AMR provides any cost benefits. So it is necessary to monitor the cost saving as well, because antibiotic stewardship programs have been proven to reduce the cost which is associated with the healthcare. Now, what are the goals of stewardship? There are basically two goals. The primary goal is to improve the clinical outcome, prevent the adverse drug reactions associated with the therapy, and reduce the resistance. And a secondary goal is to decrease the healthcare associated costs without adversely affecting the outcome. Different guidelines have recommended that you start with making a multidisciplinary antimicrobial stewardship committee, which is a subcommittee of the Pharmacy and Therapeutics Committee. And firstly, you need to appoint a leader that is accountable and also a co-leader. So preferably an infectious disease consultant. If your facility does not have one, then any experienced senior doctor with some basic training and stewardship can lead the program. And then you need the pharmacy expertise. You need to appoint a pharmacist, and preferably an ID pharmacist. Studies have shown that the effectiveness of the pharmacy and physician co-leadership was much more than the programs which were led solely by a physician. And another core member in this team would be the microbiologist. And then depending on your resources, you can try to include someone from the infection control department, someone from the IT department, an epidemiologist, and representatives from all the major specialties in which the antimicrobial use is the highest, such as a transplant physician, an oncology physician, someone from the ICUs, because the antimicrobial use is quite high in the ICUs, someone from the surgery team. So one of the strategies is to include the doctors from specialties in which you face the most hindrance, because making them part of your team would make them realize and would make them see the importance of your program. And after all, stewardship is all about building relationships. Now, CDC has given these 4 elements of hospital antibiotic stewardship program. As I've already mentioned, you need accountability. For that, you need to make someone a leader. And also you need the hospital commitment, which is most important. If the hospital does not commit, then you cannot successfully implement your program. Pharmacy expertise are required, and then you need to implement your interventions, which I've discussed in later slides. And you need to track your interventions, the impact of your interventions, and then report them and report the positive effects of your interventions. You need to educate the masses, you need to educate the doctors and the other healthcare professionals. So there are 2 strategies. The active 4 strategies are prospective audit with intervention and feedback. And the second 4 strategy is formulary restriction with pre-authorization. And then there are certain supplemental strategies which can be used in addition to these 4 strategies, such as education, making guidelines or clinical pathways, making antimicrobial order forms, optimizing the doses, and de-escalating the therapies, converting from IV to oral therapy. So the first 4 strategy is pre-authorization. It means that you restrict the use of certain antimicrobials that would only be dispensed by the pharmacy once they are reviewed and then authorized by either an ID physician or an ID pharmacist. So the antibiotic would only be approved, it is appropriate, and if it fulfills the criteria. Otherwise, the reviewer would suggest an alternative. Outcome studies with this strategy of pre-authorization have shown decreased antimicrobial use and decreased antimicrobial resistance. But there are pros and cons that are associated with this strategy. It has been shown to be more effective than other persuasive strategies, although it has demonstrated no adverse effects, and it certainly optimizes the use of antibiotics because an ID physician or an ID pharmacist first reviews the orders and then allow their approval against a pre-decided criteria. In this case, the reviewer has a direct control over the use of the antibiotics, and the primary physician uses the autonomy. However, it mainly targets the empiric use of antimicrobials to a greater extent, and that too of the restricted antibiotics. You cannot simply control or monitor the use of all the antimicrobials in a tertiary care setting. That would be time requiring and it wouldn't be possible. Also, it can cause delay in the dispensing that can sometimes be harmful. As we know in case of sepsis, if you delay the dose of the broad spectrum antibiotics, then you can directly increase the mortality of the patient. So delay can happen, and it all depends on the skills of the reviewer. Some institutions allow administration of the restricted antibiotic overnight until approval is granted the next day. This strategy also requires the availability of a reviewer at all times. Sometimes this communication can happen over the phone, and a prescriber may provide inaccurate information. So it can result in inappropriate antibiotic dispensing. So also clinicians can go and pick alternate treatments when you restrict a certain antibiotic. So you need to check, and you also need to check the changes in the usage pattern of other antibiotics, because while you're restricting one antibiotic, the use of another antibiotic can increase. So we should be focusing more on getting the right drug to the patient rather than merely restricting the drugs. So yes, it is important. Early dispensing, especially in case of sepsis, septic shock is important, but the only dose of a drug which has been proven to save lives is the first one. So you can allow this dispensing at least for 24 hours, but then you can restrict the use. Then another strategy that can be used in place of authorization, prior authorization, or you can use it in addition to this strategy. It means this is a prospective audit with feedback. It means that you are not restricting the use of an antimicrobial, you are simply monitoring it and reviewing its appropriateness after it has been dispensed. Now, the appropriateness means making sure that the cultures were sent before starting an antibiotic, and also they were verified and they showed no growth. Antibiotic is timely de-escalated or discontinued. This can require a 72-hour time period because the cultures require at least this time period to grow, and empiric use after this time period cannot be justified if the cultures still show no growth. Also, appropriateness review includes making sure that the patient is being given the right dose, frequency, also if IV to oral switch is possible. So an a pharmacist and ID physician start by first identifying a drug or an area. For example, in our institution, we decided to pick one floor for linazolid use monitoring. And then we started interventions, and then we started recording these interventions. And we also communicate our feedback to the physicians. This strategy also has its advantages or disadvantages, such as more clinical data is available. So the review is now easier. And there is a greater flexibility in the timing of recommendation. You have given the prescriber at least 72 hours, and the prescriber autonomy is also maintained. And also you are being able to de-escalate, monitor the de-escalation of antibiotics after the cultures are verified. But the disadvantages are because this has a lot of data, and this can be labor intensive. It is quite time requiring effort, and you have to identify the interventions, and you need information technology support for that. And it also may take longer to achieve reduction in the targeted antibiotic use because restriction is obviously more effective strategy. Prescribers may be reluctant to change the therapy if the patient is doing well. And this happens when a patient is on a certain combination and the physician thinks that it is a winning combination. So prescribers are usually reluctant to change the antibiotic therapy. But whether you use pre-authorization, post-antibiotic audit or feedback, or you use a combination of these two strategies, it does not matter. Implementation should serve as the foundation. So effective implementation requires the support of the hospital administration and the allocation of necessary resources. The examples of post-audit feedback in our institute is that we monitor the use of restricted antibiotics on daily basis. Also, we monitor the use of colistin every day. Now, let's review the supplemental strategies of antibiotic stewardship. The first supplemental strategy is education. Educational activities are a common tool of this program, and they should not be used solely, but in addition to other stewardship activities. No comparative studies have been done so far that show which strategy is most effective, which educational strategy is most effective. But it should engage all the healthcare professionals, from nursing staff to doctors to pharmacists. And in our institution, we hold numerous CME sessions throughout the year in order to create awareness regarding the use of antibiotics. We make advisories and guidelines. We make protocols from time to time. For example, we made this XTR typhoid advisory during the outbreak in 2019, in which we mentioned the prevention, we mentioned the treatment options and the importance of vaccination. So you can also make these kind of advisories in your institution in order to educate the healthcare professionals. Then each year during the Antibiotic Awareness Week, we do this walk around the hospital and we engage all the healthcare professionals and we give speeches and we make them realize the importance of AMR and antimicrobial stewardship. Then another stewardship strategy that you can employ is making guidelines in clinical pathways. The IDSA guidelines have already mentioned the role of developing facility-based guidelines or algorithms in order to standardize the prescribing practice. These guidelines should cover the common infectious diseases such as urinary tract infections or hospital-acquired pneumonias, etc. So not only making these guidelines, but at the end you have to implement them and you have to audit their compliance as well. Facility-specific clinical guidelines are important because they take into consideration your local susceptibility patterns and antibiotics which are already available in your formulary. So yes, we have guidelines available. We have the IDSA guidelines, the NHS guidelines, but why do we need our own guidelines? Because these are according to our own local susceptibility patterns and the antibiotics which are available. In our institution, we have developed our own antimicrobial guidelines and we keep on working towards updating these guidelines or making additional guidelines. So these are the Shifa antimicrobial guidelines, which we launched last year. And they were made, it was a combined effort by our pharmacists and our ID physician, and it was made under the light of our antibiogram and the antimicrobials which are present in our formulary. Another supplemental strategy is prescriber-led review. Now, this strategy, as the name itself indicates, the review is being done by the prescriber. So the antibiotic use by the prescriber is reviewed after you put a stop order. That can be done after 2 or 3 days. Antibiotic timeouts or stop orders are the common examples. So this physician is basically compelled to review the order, and somewhere he or she would really think, do I need this antimicrobial agent or should I switch it to some other agent? So that is the strategy. So basically this is sort of self-stewardship in which there is no prompting or direct input from the stewardship team. Success rates might also be low while using this strategy. Obviously, unless you're using any direct prompting, the success rates would be low, but it can be used somehow. And checklists, you can make certain checklists for these physicians that they have to fill at each timeout, at each stop order. So each time a physician reorders an antibiotic, he would think more deeply. Antibiotic optimization is part of the stewardship activity, and antibiotic optimization is a broad term. It includes IV to oral switch. It includes implementation of the pharmacokinetic monitoring and adjustment programs, or interventions to reduce the duration of the antibiotics. It can also include the allergy assessments. So I would discuss all of these strategies in detail. First of all, PK monitoring and the adjustment programs. So ASP implementation of the PK monitoring program for the antimicrobials, such as these may include antimicrobials such as aminoglycoside, vancomycin, because these programs can reduce the cost and adverse drug reactions. IDSA guidelines have recommended a pharmacokinetic monitoring program, and as randomized studies have shown that individualized pharmacokinetic monitoring and adjustment as compared to the standard dosing is associated with fewer adverse drug reactions, and it decreases the length of hospital stay and mortality. So in Shifa International Hospital, we have developed the Vancomycin Protocol, which mentions in detail the weight-based dosing, the dosing changes according to the trough levels, and the continuous infusion protocol in patients who fail to achieve the trough levels. So this protocol was initially implemented in our ICUs and it showed successful results there. Similarly, one of our ID pharmacists made this extended antibiotic infusion protocol. And we know that the extended infusion has shown better results as compared to the standard dosing. So you can also target the dosing strategy and you can help with the antimicrobial stewardship. It can help with the stewardship efforts in improving the clinical outcomes of the patients. Then IV to oral switch, some of us might already be familiar with its importance because the IV therapy is associated with a higher risk of infections, and we try to switch to oral therapy as soon as possible. So timely transition from IV to oral is one of the supplemental strategies. It can reduce the cost and it can reduce length of hospitalization without compromising the efficacy or safety. Then the allergy assessments are important because we know that most of the patients that report penicillin allergy, they are not truly allergic. And according to one CDC report, 9 out of 10 patients that report a penicillin allergy are not truly allergic. So what happens? The physicians are more inclined to prescribe macrolides or fluoroquinolones as an alternate. But penicillin is the first line agent. It should be used more. And if you perform the skin testing, if you properly perform the skin testing, it can help you differentiate true allergy from the false one. And these patients can be given penicillins and not broader spectrum antimicrobials. Then you can make certain interventions to reduce the antibiotic therapy to the shortest effective duration. As I've already mentioned in the previous slide, that different RCTs have now proven that shorter is better. So you can go for the shorter duration of therapy if the patient has no other indication. In our institute, in Shifa International Hospital, we on daily basis run this report, which is of antibiotics that are given more than 10 days or more than 15 days. It also includes the antibiotics which have been given more than 30 days. Certain conditions do require longer duration of therapy, but we make sure that the use is justified, and this is how we are making our efforts on daily-to-day basis. We are monitoring the use and monitoring the duration as well. Now, I've already mentioned that the microbiology department plays a very important role, just like the pharmacy department. So microbiology and lab, they also have to work in collaboration. And the first strategy is to develop a stratified antibiogram. So antibiograms show your local susceptibility patterns, but if they're stratified by location or by age, it can lead to improved empiric therapy. And it can also help in making optimized treatment guidelines. Therefore, already various guidelines have already highlighted its importance. In our institution, we have stratified antibiogram according to the locations, such as outpatient or inpatient. A single antibiogram which is not stratified and is hospital-wide can mask the important susceptibility differences across the institution. Certain antibiotic-resistant organisms are sometimes more common in the ICUs than in the non-ICU settings. That is why you need the stratified antibiograms. One of the strategies which is being used by our lab as well is the selective or cascade reporting of the antibiotic susceptibility result. So there is limited data which suggests or demonstrates the impact of this strategy. But selective reporting basically is the practice of reporting susceptibility results from a limited number of antimicrobials instead of all the tested ones. For example, a lab would not report susceptibility results of linezolid if Enterococci or Staphylococcus aureus is susceptible to the first line agent, that is vancomycin. So it means susceptibility results of secondary antibiotics, which are more costly or broader spectrum, are not reported unless the organism is resistant to the primary agent. Diagnostic stewardship is also very important in identifying the diagnosis as early as possible. It means that the patient gets the right test at the right time. And it includes different techniques such as rapid viral testing, which means a decrease in the inappropriate use of the antimicrobials. It can be done by the rapid antigen or immunoassay, etc. It has been associated with decreased inappropriate antimicrobial use because the physicians tend to give unnecessary antimicrobials whenever a patient presents with respiratory symptoms such as cough or flu, and it is often difficult to differentiate a bacterial illness from viral illness. So a rapid PCR test would definitely help, but these tests are often times expensive and they're not readily available. Another rapid diagnostic testing can be done on the blood cultures using molecular assays or mass spectrometry to identify different bacterial species and their susceptibilities. This can be combined with the conventional culture and routine reporting, which takes at least 3 to 5 days. De-escalation is the opposite of escalation. It means you are switching from broader spectrum antimicrobial therapy to the narrow spectrum. And the lab which you can use, the lab value which you can use in order to de-escalate is procalcitonin. And it has different studies have shown its role in de-escalation. And it is a more specific marker as compared to CRP. CRP is non-specific. It can be raised in inflammation as well. Procalcitonin is released in response to the bacterial infections, and when you start appropriate therapy within 6 to 12 hours, it can decrease, and daily decrease is around 50% with appropriate infection control. But it does have its limitations, such as atypical organisms other than Legionella species. They do not induce procalcitonin response. And interferon gamma, which is released in response to the viral infections, can block its upregulation. In our institution, we do use procalcitonin in order to de-escalate the broader spectrum antimicrobial therapy. Then the last step is to measure your antimicrobial stewardship efforts, because every antimicrobial stewardship program must measure its antibiotic use. ASP should measure the use as it gives you an idea whether your stewardship efforts have decreased the antimicrobial use or not. And even if the use is increased in a certain specialty, then you can target that specialty and you can put your focus on that one. So two standardized methods are days of therapy and defined daily doses, which can be used for the measurement of antimicrobial use. Days of therapy are preferred over defined daily doses. There is a weak recommendation by the IDSA guidelines because defined daily doses, which is the average maintenance dose per day, its calculation can be impacted by the renal adjusted doses. For example, if someone is taking meropenem, the usual dose per day would be 3 grams, 1 gram Q8 hourly. But in a renal compromised patient, which is on dialysis, it would be 500 mg per day. So also the pediatric doses, which are weight-based doses, they're not covered by the defined daily doses data. So that is why the days of therapy is preferred. But in both, it can be performed, in adult and pediatric population, but it is recommended to measure the antibiotic cost, whether you use DOT or whether you use DDD. And also, instead of the purchasing data, we know that the antimicrobial stewardship program results in cost savings So it is very important to monitor the cost-saving data in order to justify your stewardship program. So you can use this strategy in order to measure the expenditure on the antibiotics. Here, I would like to discuss in detail defined daily doses. Although time is limited, because this is important. How do you measure your antibiotic use? It includes basically, it is a statistical measure of the drug consumption by the WHO and the average maintenance dose per day. So actually, the drug consumption can be expressed in cost, number of prescription, or by the physical quantity of drugs. However, these variables can vary across different countries, so you cannot compare at an international level. So in order to address this issue, defined daily doses was created. And in our institution, we calculate the DDD data on quarterly basis, and we also measure the use of antimicrobial specialty wise. There are different advantages, such as it examines the changes in drug utilization over time, and you can make international comparisons as well. And you can evaluate the effect of your intervention on the antimicrobial use. Also, you can document the relative therapy intensity with various groups of drugs, and you can follow the changes in the use of a certain antimicrobial drug class. So you can also evaluate the regulatory effects of your interventions on the prescribing pattern as well. Next step after the defined daily doses is the drug utilization review, because DDD helps us in identifying the problematic drug or the problematic area. Now, next step is to do a utilization review. Suppose your meropenem use was the highest in a certain specialty, so you would go for a detailed and comprehensive review of meropenem use in all these patients. But it cannot be possible, it wouldn't be possible to evaluate the use of meropenem in all of these patients. So you randomly pick at least 1/10 of the admitted patients, and you evaluate the use of meropenem in them. And it is a comprehensive review. You have to evaluate each and everything, the dosing, the frequency, whether it was culture-based therapy or not. And this review can be done prospectively, it can be done retrospectively, or concurrently. Now, let's discuss the different challenges that the Antimicrobial Stewardship Program faces. And first of all, it is the lack of resources such as money, staff, and time. Then obviously you need trained staff, which is trained in the stewardship. And also you need to be able to improve your lab techniques, because as I've already mentioned, lab plays a crucial role. And if the lab tests are not readily available, and if they are not up to date, then it can lead to poor outcomes as well. Then you should be able to track the antibiotic use, such as I've already mentioned, we track the use by performing DDDs. And then you should be able to report the antimicrobial use to the physicians and also to the hospital administrators. CDC has already given its 12 steps to prevent the antimicrobial resistance in hospitalized adults. So the first step is to vaccinate. You get prevention from the diseases that can be prevented. Second one is to get the catheters out. So IV to oral switch is important, because if you're stopping the IV antimicrobials, you're removing the source of infection. And culture-based therapy is important. Then you access the experts. You get the right members in your team. You practice the antimicrobial control. You use your local data. You use your local antibiogram, the drugs which are available in your formulary, and you treat the infection, not contamination, such as asymptomatic infections in case of asymptomatic bacteriuria, or the ones which are just merely colonization. You do not treat such infections which are even not causing any symptoms. So also you should say when to say no. And mostly we see that the vancomycin is the most irrationally prescribed antimicrobial agent. Stop treatment when the patient is cured, and no need to continue the duration, no need to continue just because it is mentioned in a guideline that you have to give it for a certain number of days. You can stop earlier because a number of studies have already proven it, that shorter duration is equally efficacious. And isolate the pathogen. You should always put these patients which are infectious, which are infected with ESPL pathogens or MDR infections. You should isolate them from other patients so you can prevent the transmission. And you should be able to break the chain. You have to make your own new guidelines. You have to set new practices. How you can overcome these challenges? You need support from the hospital leadership. Without the support from hospital leadership, it is simply not possible. Then identify one specialty or identify one problematic drug and start from there. So it should be a stepwise approach, and start smart with the low hanging fruit, ones you can easily access, and ensure appropriate policies or guidelines are in place. So not just making the facility-based guidelines, but also making sure that they are being followed and the practice is standardized. Also, education is quite important. As much as you educate, the outcomes would be improved. And then finally, you have to monitor the impact of your antimicrobial stewardship program. In the end, you have to maintain a critical balance of the antimicrobial stewardship. The empiric use is unavoidable. It is sometimes even necessary in cases of septic shock. You cannot simply withhold a medicine because it is being given empirically. But the important thing is that you send the cultures at the time of initiation. And when those cultures are verified and they show no growth, you immediately either de-escalate the therapy or you discontinue the therapy. And also at the same time, you have to make sure that the broad spectrum antimicrobials, they're not being overused, because that is what is causing resistance. Thank you very much. I would like to now answer the questions. Okay, I've received one question. Unfortunately, my mic was on mute. How we can decide which empiric therapy is the best? So empiric therapy is usually governed by the clinical judgment of the physician. It also depends on the previous exposure of the patient to antimicrobial agents. Suppose if someone has taken the first line agents during previous hospital admission and has now been readmitted within 3 months. So now you are suspecting some pathogen which is obviously resistant to the first line agent. So you would start a broader spectrum antimicrobial. But what is important is that you send the cultures at the time of starting the empiric therapy. And these cultures are usually verified within 2 or 3 days. And then you can de-escalate. Can PNTC play a role to monitor the irrational prescribing? It's not the PNTC which is directly monitoring this program. It is Antimicrobial Stewardship Program. The Stewardship Committee is basically responsible, and it is a subcommittee of the PNTC. What tools and resources can be used to conduct the antimicrobial stewardship program effectively? I have already mentioned in detail, but the core strategies are prior authorization, which requires the restriction of antimicrobials, certain antimicrobials that you feel like should be restricted, their use should be restricted. And there's another strategy, which is the audit, which is the prospective audit and feedback. Then there are supplemental strategies, which I have mentioned, such as IV to oral switch, dose optimization, educating your staff, improving your lab and diagnostics, etc. How long should we continue the empiric therapy? It depends when the cultures are verified. Usually it is for 72 hours. If we switch to a narrow spectrum, is there any chance of developing resistance of other microbes? The broader spectrum antimicrobials are linked to resistance. So if you are switching timely and not there's not a delay in switching, then you can avoid resistance. What are the common outcomes of a prospective DUR? The outcomes are that when you are reviewing the drug utilization, you can identify the problematic patients, and you can simply call the physicians and give them your feedback. So it depends whether they are compliant or not. Why combination antibiotic therapy is becoming a norm in hospitals, especially the combination of ceftriaxone. It is a requirement, especially when you have such a high rate of multi-drug resistant organisms in your hospital and the prevalence is high. So you have to start a combination therapy, and usually it is the empiric therapy which is given. And it must include a gram-positive, gram-negative, and anaerobic coverage sometimes. But whenever the cultures are verified, you should always de-escalate and narrow it down. Another question is, how can we manage this at pharmacies? So being a pharmacist, obviously the order comes, you can review the antimicrobial order. I don't know if at your institution they put more focus on sending the cultures, but here we review the cultures, and we make sure that the cultures are timely sent, and the therapy is at least culture based. Then you can also make sure that the dosing is correct. It is according to the, it is adjusted. That is, if it requires any renal dose or hepatic dose adjustments, or the frequency should be okay. Even if two antimicrobials are being given which have the same spectrum, you can make sure that does not happen. So in a number of ways, you can manage the stewardship at your pharmacy, and it can require some effort. It is not easy. It also requires persuasion. Another question is, can we educate the public about antimicrobial resistance? That is, it is a general trend. Being a healthcare professional, as I mentioned earlier, that we all are the guardians of the this antimicrobial use. We are all responsible for stewardship. So you can educate by either making a Facebook page or a page on Instagram, just showing the importance of this AMR, the emerging crisis of resistance, and how we can tackle it. If your institution does not have an antimicrobial stewardship committee, how you can tackle this problem? You can take someone who you simply need a leader, basically, who can be held accountable for the antimicrobial stewardship. And if your institution does not have an infectious disease consultant, you can ask anyone, you can invite anyone, any senior physician who is willing to do this and who is interested in dealing with this issue of the AMR. And then, of course, you need, so at least 2 members or 3 members are more than enough in institutes that have limited resources, such as a pharmacist should be in this team, and a microbiologist, or at least a physician and a pharmacist. Another question is, what makes patients believe that they are allergic to penicillin? Minor adverse drug reactions. Yes, sometimes a misconception, it could be a rash due to some other reason, and the patient might believe that he or she simply experienced allergy due to that drug. So you always have to make sure that the allergy was true. Another important question is, what a clinician do in cases of septic shock or sepsis. This is important because the Surviving Sepsis Campaign guidelines recommend using broad spectrum antimicrobials within 1 hour of therapy. If you do not give the patient broad spectrum antimicrobials, the mortality increases. So you should never withhold the dose of the antibiotic within 1 hour. At least the patient has to be administered the antibiotic. So that is important. But after, because the bundle also includes taking cultures before the antibiotic therapy is given. So when the cultures are verified, then one can always de-escalate. But mostly when a patient is septic, it means that the patient first becomes septic and then goes into septic shock. So the patient definitely has some infection which is life threatening, and antibiotics, they must be given. You cannot stop them. Another question is, what are the steps in conducting a drug utilization evaluation? The first step is to identify the patients, and you do this without any biasness. You pick the patients randomly, and then you check their therapy in detail. You check the drug utilization in detail, why the antibiotic was prescribed, for how many days it was prescribed, when was the start date, when was the stop date, the days of therapy, and why it was given, the rationale of the therapy. So a complete information is provided in the utilization review, and ideally it should be at least 1/10 of the patients. Significance of the drug utilization review is that you can find out whether the increased antimicrobial use, because you only do drug utilization review when you realize that the use of a certain drug is increasing. Then you go for the DUR. But after performing this DUR, you realize whether the use was justified or not, because you have reviewed in detail the use of the antibiotic. Thank you everyone for attending today's session. Unfortunately, there are a lot of questions and our time is finished. So please send your questions at drug.information, and we will answer you there. And hopefully we will all be able to now perform some activities at our level, perform the stewardship activities at our level, and hopefully this presentation was useful. Thank you so much for joining.